Hi, my name is Martina Ješková. I'm DNS instructor and Iyengar yoga teacher focusing on patients with pelvic floor dysfunctions. On this video, I would like to demonstrate my work with a pregnant client. We have to understand that pregnancy is a normal physiological part of healthy woman's condition. It does not have to be painful or problematic. And we should not normalize any pain or discomfort during the pregnancy, as they can create problems during the labor. Pain and problems may arise from 4 major reasons. First, poor physical condition. Often a woman cannot carry her baby to full term or is not strong enough to go through the natural birth process. Second, imbalanced physical condition. The opposite can be also true when a woman has intense or long-term core training. It can be then difficult to voluntarily relax the pelvic floor muscles and allow the natural birth canal. Third, social psychological elements, where a woman may choose or be advised to have a caesarean birth due to multiple factors, including past Caesar section birth difficulties. The number of caesarean sections is continuously increasing around the world. This is not always due to women's health condition, but can also be because the medical system does not fully support a woman's capacity to carry a baby to term and give birth naturally. This is an essential task for physiotherapists and other manual therapists to assist pregnant women in trusting and taking care of their bodies during pregnancy, labor, and during the postpartum period. Fourth, medical emergency. If the natural labor is not possible, we really appreciate the caesarean method for giving life to so many babies that may have otherwise not survived. The female body is in transition and keeps changing during the pregnancy. During the pregnancy, the secretion of progesterone and relaxin increases, which causes soft tissue laxity. This occurs to ease delivery, but also relaxes the other ligaments in the body, which can affect support structures. Another hormone that changes the level is estrogen, that helps fetus to grow. From my perspective as a physiotherapist, probably the biggest change is the position of the diaphragm. Because the baby is growing very rapidly, especially in the end of the pregnancy, and the uterus is increasing the size, the diaphragm is pushed up by the uterus and is losing the physiological function to move down and up during respiration. For every pregnant lady, it's very important to keep this physiological movement of the diaphragm as long as possible. So we have to teach all pregnant women how to breathe correctly. We have to also work on flexibility of their chest, because they need to open more intercostal spaces to use their functional capacity of their chest. Finally, the diaphragm has to keep the function moving down towards the pelvic floor, because this is then the main muscle that is pushing the baby out through the birth canal. The next that is changed is the position of the stomach. The stomach is also pushed up towards the diaphragm by uterus, and pregnant ladies may suffer with gastroesophageal reflux. To decrease this discomfort, we can use the proper breathing technique to activate all diaphragm fibers correctly to balance tonus of lower esophageal sphincter and normalize the position of stomach. The center of mass of pregnant lady is shifted forward due to increased size of abdominal wall, and the lumbar spine becomes more lordotic, which increases the tension of paraspinals. We have to kind of strengthen the abdominals to hold the baby back as much as possible. So when we assess the pregnant lady, we assess the typical stand position from front, from the back, and from the side. So what can we see here is that this lady, 36-week pregnant, she's using a larger base of support, so she stands with the feet more apart. We can also see that her pelvis is in anterior pelvic tilt. If we have a look at abdominal wall, we can see some kind of asymmetry of abdominal wall. The lower abdominal wall has a more concavity on the left than on the right, which can be caused by the position of the baby, but also it can be caused by a tonus of the muscles, asymmetrical tonus of the muscles. So we have to see or observe if it's constant or if it keeps changing. We can also see that the left thoracobrachial triangle is a little bit smaller than the right one. Then we can see a little bit more inspiratory position of the chest, protraction of the shoulders. Shoulders are at the same level. And we can also see that the chest looks a little bit shorter, which means I call that like the chest is a little bit dropped down. From the back view, from the back, so we can see that the foot position is quite okay. We can see a little bit hyperextension in the knees. We see little asymmetry in the pelvis position. It looks like the shift is to the right. We can see also increased lumbar lordosis, a little bit bigger thoracic kyphosis, and protraction of the shoulders. Also, the arms are internally rotated. If you have a look on this postero-lateral abdominal wall and we test the intra-abdominal pressure and diaphragm test, and I ask the patient to push my fingers out, it can give you also the information if this lady with open scissor sign in late pregnancy is still able to open these postero-lateral parts. What I can feel here is it's a little bit easier on the left, it's a little bit more difficult on the right. So I can check the position of the pelvis. It looks, it's quite symmetrical, it's even in this plane. So from the side, we can see that the anterior pelvic tilt is quite strong and the chest is dropped down. We also see a typical open scissor sign with oblique position of the diaphragm and pelvic floor. The body weight is shifted forward. So if we think about the treatment, we need to move her center of mass back. To allow that to happen, we must elongate paraspinals and activate transversus abdominis and oblique muscle chains to move the position of baby a little bit back. Then we have to upright her thoracic spine and open intercostal spaces of the chest for better respiration. All these little changes will help to bring the diaphragm and pelvic floor in more parallel position, which will improve the respiration pattern and help during the labor. So another very easy test is bending forward, bending backwards, and also lateral flexion to see how the spine behaves. And especially, I will be very curious about flexion of the lumbar spine and extension of the thoracic spine. So, can you bend forward, please? So feet more apart, it's necessary. So this flexion is quite nice, so we can see nice and fluent flexion in the thoracic spine. The lumbar spine is a little bit resisting to the flexion, but I'm very happy about a kind of opening of this part of abdominal wall. Okay, thank you. Come up. Now place your hands on your hips and do extension. So I also observe how much she can extend. It's not much, and you can see that all the extension goes mainly from the lumbar spine, and thoracic spine stays kind of stiff. So from the back view, we can also observe lateral flexion to one side. And you can nicely see how the spine, lumbar spine stays in a lordosis, and she really locks her body in a postero-lateral abdominal wall. And come up and go to the other side. Yeah, it's a little bit better to the left side. And come up. I would like to see also standing on one leg. So if you can shift the weight to the right and bend the left knee up. So I'm observing stability of the pelvis, and go back and do the same on the left. Perfect. Here we can see a little bit more oblique position of the pelvis, and go back. Perfect. Thank you. So if we have a look again on abdominal wall in sitting, we can see that these areas are quite narrow on such a big abdominal wall, and also the baby goes a lot of forward, so which is moving the weight of the pregnant woman more forward. So my therapy would be to release this part of abdominal wall to create a space for the baby to move a little bit more up towards this space, which will create more comfort for the baby. We also have to lift the chest a little bit more up by maintaining the connection of the chest with the pelvis, like you have learned in DNS. We need to relax the Pec Majors, Pec Minors, and we need to relax the intercostal spaces. Another soft tissue work will be in a lower abdominal wall. As we saw from the front, that the left side was more tight than the right side. So we can a little bit more release the abdominal wall from the left and from the symphysis side. And then we will start to concentrically activate the abdominals. So the first will be work on soft tissues on the back. So can you lie on the back? So always you have to ask the pregnant ladies if they can still stay some time on their back. You have to communicate with them if they feel okay, if they don't feel nausea. Are you okay?
Yes.
Yes. Before soft tissue technique, we need to do one more functional assessment of pregnant lady, especially if she is in the end of the pregnancy, is test how she can push, which is a test of a direction of intra-abdominal pressure, direction of pressure from the diaphragm towards the pelvic floor. So I usually place the hands on lower abdominal wall, and I ask the lady to push my hand or fingers out, or to push against the baby down. So if I find something like that, I can see that the pressure is not down against the pelvic floor, but the pressure, the diaphragm, especially the oblique position of the diaphragm, is pushing against the abdominal wall forward, which can be a big problem for the labor, because here is no birth canal. So she has to learn how to activate the abdominal wall and how to push against the pelvic floor in a little bit different direction that she did before. So if I change the conditions and I a little bit more elongate her lumbar spine, so can you push the feet down and lift the buttock, and then elongate the lumbar spine, good, and then relax. she has now a little bit better condition from the shape of the lumbar spine. The diaphragm is more parallel towards the pelvic floor. And now, because this is a patient that is already instructed about some exercises, I can ask her to gently activate abdominal wall and again try to push against the pelvic floor. And now you can see there is a little bulging of abdominal wall still, but the pressure goes much better towards the pelvic floor, towards the pelvis. So I would like to see after the treatment that the lady that is preparing herself for the birth has the capacity to provide this test this way. So I will start with the soft tissue around the chest first. So I will release the intercostal spaces here. So first I will examine or assess the soft tissue, and I can see that this movement in this direction is very restricted. So the barrier is quite firm. The restriction here is not so bad. I would like to open also these areas of postero-lateral abdominal wall. So when I work with the soft tissue, I always work to the first barrier, and then I'm waiting for release. The patient is normally breathing, and I follow the respiration rhythm. And I can also feel that the baby keeps contact with me as well. You can also observe if the baby likes the therapy or does not like the therapy. The palpation will tell you, and also the rhythm of the movement of the baby will tell you a lot. During the pregnancy, we have to understand that we do not treat only one person, but we take care of two at least. Okay. So after I release the chest, the fascia around the chest, I can go towards the postero-lateral abdominal wall. My top hand is fixing a little bit, very gently, the chest, and my bottom hand is working with the barrier of the postero-lateral abdominal wall. So I'm stretching, and I can also gently guide the respiration and ask the patient to breathe against my left hand. So the therapy leads to better centration of the chest, of the lower or abdominal wall and pelvis. Excellent. So after we released the fascia around the chest, we released also the postero-lateral abdominal wall to centrate the chest a little bit better. We can also release the intercostal spaces because the pregnant lady cannot push or breathe with the diaphragm so much caudally, and she needs to open more intercostal spaces. So what I can do is I can place my fingers around the chest, and I can be in the direction of intercostal spaces, and I can do soft tissue technique that will help to release this area. So when I'm working with both hands, my bottom hand is more palpating and the top hand is more moving. So this releases the soft tissue, but also it brings more awareness into this area. After I do it on both sides, I can place my hands to both sides of the chest. I can gently approximate the chest towards the shoulder blades with the movement of the chest gently back and up to create more space for the baby. Breathe. And then I can ask the patient to inhale against my hands to the sides as a contact breathing. And now you can see she has the capacity to open the chest much better. So with my hands, I'm gently resisting the chest. And if there is no strength of the chest to inhale against my hands, I'm more like guiding the respiration to the sides. So initially resisting, later going like one little step ahead of her inhalation. Excellent. So now, after releasing the chest, I can go and stretch and mobilize the lumbar spine. So the side-lying position is very good for mobilization of the lumbar spine, but also to stretch the paraspinals, to elongate, to create a traction on the lumbar spine, because we understand we need to have more space to shift the baby a little bit more backwards. So from typical side-lying position, I will flex the top leg and I will have to more externally rotate in the hip to create a space for abdominal wall. So the thigh is not pushing much against the baby, because the woman needs to also breathe against the pelvis. Then I will place my hand on lower lumbar spine or on the sacrum, and then through the chest, through the sternum, I will rotate the lady to the other side. I try to keep the spine as much in the axis as possible. Okay? So I will flex here a little bit more. Keep here. Okay for you? Okay. Now inhale. And as you exhale, you can turn the head a little bit more to the right. And I'm creating a traction on the lumbar spine. And then I'm gently rotating the pelvis towards me. Again, inhale. Exhale. Very good. After I release the lumbar spine, I can ask my patient to push with the shin against me. So she's doing a little bit more extension in the knee, a little bit more if you can. Very good. So she's actively pushing, she's actively stretching all her posterior chain, and she keeps breathing to the sides like you learned before. Very good. And relax, go slowly back. Another very good position for creating a movement or mobility in a lumbar spine to flexion and thoracic spine to extension is a cat-camel position. So with the knees apart, toes together, hands below the shoulders, classical quadruped position, we will start with the lumbar spine flexion, which means I will ask the patient to tilt the pelvis posteriorly from the lower segment to create as much flexion as she can in the lumbar spine. Then the thoracic spine continues, then the head. She inhales gently to open these spaces, and then she will go into extension from the thoracic spine first, cervical spine, and the lumbar spine follows. Exhale. And then again, start to tilt the pelvis. Slowly inhale, opening these spaces up, and then exhaling, extension in the cervical spine, keeping the spine long, and of course the lumbar spine will go in gentle extension. Last time, flex. Inhale, and then exhale and elongate from the thoracic spine. Good. All the time you try to keep the shoulders as much centrated as possible, shoulder blades in caudal position and spinal elongation. Of course, we pay attention of the support on the hands and also support on the shins, not kneecaps only. Quadruped position is quite nice for all pregnant women because they feel nice relaxation because the baby is not pushing on a pelvic floor. Then we can use low kneeling position. So now the knees, they have to be really apart, especially in late pregnancies, and you will sit on the heels. So the baby has to have enough space between the thighs. Then support on the elbows, hands facing down. So this exercise will mobilize the thoracic spine into extension. So head is in one line with the rest of the body, support on the shins and on the forearms. I will try to keep the sacrum in elongation. Inhale. Inhale here. Very good. And with exhalation, try to elongate the thoracic spine forward. Like I'm pulling you here. You need to be a little bit taller, longer. Inhale. Exhale. Elongate the thoracic spine. Tilt the pelvis a little bit back. Gently tilt the pelvis back. Inhale here. And as you exhale, try to elongate the thoracic spine forward. And the patients, very often they feel a little of sore here, which is the mobilization effect of this exercise. So shoulder blades are moving towards the pelvis in a neutral position. Spine is elongating forward. These postero-lateral abdominal walls are opening with every inhalation, and the pelvis has to feel kind of a traction caudally towards the supporting zones on the shins. Good. And relax. So next position, what we are going to do is a position from yoga that is called Supta Badha Konasana. And the position opens the area of the pelvis. So we create a little bit more space for the baby in the pelvis. And I'm also using a support for a patient's chest to create a more space in chest for respiration. So we have a loop on the belt, and the loop will be placed around the sacrum. Then the belt will be placed around the feet, and the feet are facing to each other, and then we can tighten the belt. Very good. Tighten the belt. Actually, the patient can do it on her own. Very good. So we have kind of like a connection, approximation between the pelvis area and between the legs. Then the patient will place her hands behind the back, tuck the pelvis gently under. Very good, to lengthen the lumbar spine. And then she will slowly lie down on this support. The support will be below the shoulder blades, will approximate the shoulder blades towards the chest. Hands, arms will be placed here. So the spine will be in gentle extension. Now, to avoid any tension in a lumbar paraspinals, you can gently tuck the pelvis under again if you can. Very good. And I can help with a little of traction of the sacrum towards the heels. So do you feel comfortable in here? Yes. Good. So this position is gentle extension, but there is no hypertonus of paraspinals. The patient has a support for the shoulder blades, which causes also a little bit more of opening of the chest, uprighting of the thoracic spine. We mobilized the thoracic spine in a previous exercise. And also the belt around the sacrum, not around the lumbar spine, but around the sacrum, is kind of pulling the sacrum towards the heels, which also causes an elongation, traction on that extended spine. So we can do also contact breathing here. You can also place a hand here on the sternum to create a space between the support and between therapist hand. And the patient can also feel the respiration along the spine. So if the curve is nice, elongated, we actually prevent to bulge even the big abdominal wall, and the baby can nicely descend back towards the spine. And it has enough space now in any part of abdominal wall. The body becomes a little bit taller, the chest becomes a little bit more mobilized and open. How to get from this position back? You bring the hands back. You bring gently the knees together, and then you roll over the side. Okay. So the next position for mobility of the chest, activation and facilitation of oblique abdominal muscles, opening the intercostal spaces, is Bharadvajasana on the chair. So step in the chair. Ideally, if you have a chair like this. After, I will show you an option if you have a different type of chair. But if you have an option of you have a chair like this, this is ideal. So again, the legs are in abduction to have a space for abdominal wall. The shins are in vertical position, both of them, and the foot is active. Doesn't mean if you sit on the chair that the legs are not working at all. They are still supporting the whole body. We try to keep spine as much uprighted as possible, which we can create from the support. And again, create a length in abdominal wall, which means being a little bit taller. And then you will rotate the chest towards the right first. You can hold on the back of the chair, and you can hold on the seat of the chair. First, what I would like to have is fully uprighted spine. So again, here is a little bit anterior tilt. So can you a little bit tilt the pelvis back? Upright from the thoracic spine. Roll the shoulders back. Move the scapulas down along the chest. Very good. You inhale to the sides of the chest, and then you exhale and you gently twist you pull the body towards the left arm and you move the body to the right. So the left arm is pulling, the right arm is more pushing. Inhale and exhale. The inhalation should increase the length, create a traction on the spine, open the intercostal spaces. The exhalation should allow the body to go gently deeper to the twist. Excellent. And then you do it on the other side. So if you do not have an option of this kind of chair and you have a chair with a full back, you have to sit a little bit differently. So you will sit facing this way. So you will sit like diagonally in the chair. So you can gently support the sacrum of this part of the chair. So again, feet are supporting, the trunk is elongated, uprighted up. We respect the DNS principle of the parallelity of the diaphragm and pelvic floor. And then you inhale, and with exhalation, you gently twist to the side. Again, support on the feet, sacrum long, traction on the lumbar spine created. Inhale to the sides, and as you exhale, gently twist the chest to the right. We try to keep the shoulders even, so elongate gently through the right arm. Inhale to the sides, into intercostal spaces, and then exhale and twist. Very good. And relax. So, after relaxing the chest, after releasing the little hypertonus in upper abdominal wall, which means creating a space for the baby, we can start to gently move the baby up towards the diaphragm and towards the lumbar spine. So the next step will be to do a soft tissue work in lower abdominal wall here, because in the beginning we found there was a little bit higher tonus on the left, and also the belly was too much forward and gently hanging like a down over the symphysis. So I would like to relax the lower abdominal wall and then activate the abdominal wall a little bit more concentrically to hold the baby backwards. So my hand will be in lower abdominal wall, and again I will assess which direction the abdominal wall does not want to move. What is the resistance? And I found that the resistance is mainly like a cranially. So I can move gently in, gently out, but working up creates a resistance. So I will ask the patient, just inhale, and as you exhale, relax, and I will go with the barrier. And again, inhale and exhale. I don't want her to push against my hand like we did in the test, but I would like the patient to be already aware about breathing, not forward, but breathing down, like in a sagittal plane towards the pelvis, like along the spine. And I continue with my patient's rhythm, doing the soft tissue techniques and relaxing the lower abdominal wall. I can also work from the other side if it's necessary, but here it's quite okay. But where I can see a gently tension is here, just in the middle. So I will take a uterus like very, very close to the symphysis. Are you okay? And then you inhale gently down, and as you exhale, I will gently move, but very gently move the baby up to the new open space. Inhale, and as you exhale, just relax, and I'm doing the work. So my focus is to centrate the baby in the mom's body, centrate the baby backwards, centrate the baby comparing right and left side, and in the middle between the chest and between the pelvis. So the baby is not too much down in the pelvis and not too much up towards the chest. Inhale also backwards in postero-lateral abdominal wall, and exhale. So you're actually welcoming the baby up and back. Nice. Good. So the next step will be active exercise. So you stay in this position, and we will do 3-month supine position exercise where the support is on the sacrum, TL junction, shoulder blades, and back of the head. Of course, if the woman is in a very good condition, she can actually exercise without any support. But I think for the gentle practice, especially in a late pregnancies, it's very good to support the legs. So the heels should be always a little bit higher than the knees to bring better position of the femurs and the pelvis. I would like you to breathe here as well. Very good. And we were talking about activation of oblique abdominal chains. And the great exercise is when you bring a hand with the fingers pushing against the medial knee. Good. So it's not activation of the adductors, it's activation of oblique muscles. So from the coral position of the shoulder blade, with a gentle external rotation in the arm, you are gently pushing against the knee, and from the pelvis you are pushing against the arm, which activates the oblique abdominal chains. You can also place the other hand, you can also place the other hand here on abdominal wall to feel that you are not breathing too much up towards the ceiling, but the breath is more guided on your postero-lateral abdominal wall. If you want to increase the challenge, you can raise the heel a little bit more up and keeping the concentric activation of oblique abdominal chains. Very good. And here the lady also learns the direction of intra-abdominal pressure distribution gently towards the pelvic floor, which will also help during the natural birth. So here we can see in the details that this abdominal wall has a diastasis here. So when you are raising the leg up, or when you raise the head up, you can see that here is the diastasis as a bulge. To prevent the diastasis is to create a parallel position between the diaphragm and between the pelvic floor, plus actively, concentrically activate oblique abdominals to create a good support from the abdominal wall for abdominal pressure distribution. So we can help with this exercise that I showed before. So you are pushing against the medial knee. wait, you actively activate the concentric activation of oblique abdominals, and then you can raise the leg up. Very good. You keep the parallel position of the diaphragm with the concentric activation of abdominal wall, including transversus abdominis and oblique muscle chains. So another very good position, DNS position to activate oblique abdominals to prevent the diastasis is oblique sit position. So we can have a high oblique sit or low oblique sit. With the pregnant ladies, I prefer the low oblique sit position because it's a little bit easier. Again, easier variation is when the top leg is supporting, gently supporting. It's not the main support, but it's supporting, it's helping with the pelvis lift. So the chest is uprighted in one line, support on the forearm, support on the greater trochanter. Then you will gently shift the weight towards the lateral knee, and then you will activate the oblique abdominals and lift the pelvis. And going back down, twist the pelvis back. And again, caudal position of the shoulder blade, activation of oblique abdominal muscles, and going back. Are you okay? And again, twist, activate the abdominal muscles, keep the baby as much back as possible, and going back. A little bit more challenging variation is with this leg lifted up. Do you want to bring the elbow a little bit closer? Good. So I'm holding this leg in external rotation again to create a space for the uterus. Support is the same. I'm helping gently from here and monitoring what the abdominal wall is also doing. So twist gently forward, shift the weight, activate the abdominal wall, and step with the left leg forward. Excellent. And then going back, twisting the pelvis. And again, going forward, stepping with the left leg forward, and going back. This is also activation of lateral stabilizers of the hip on the bottom side, which we saw, especially on the left side, it was weak in a first test. Another very good variation of quadruped position that is accepted very well by pregnant ladies is a bear position. So the lumbar spine is not loaded, and the bear position is a little bit inverted position, which also helps the pelvic floor to rest. Also, we were talking in this case of lady that we want to create a space in upper abdominal wall for the baby to move the baby a little bit up and backwards. And that's what we can do also here, because the position is upside down. So after all these exercises and treatment and soft tissues, we can continue to bear position if it's tolerated. So from quadruped position, you tuck the toes under and you walk the hands a little bit closer towards the knees. You keep the shoulder blades in a caudal position and centrated position. And then you spread your fingers, spread your palms, and you lift the pelvis gently up. Good, you can stay a little bit more forward here. So external rotation in the shoulders, fully uprighted lumbar spine, keeping centration of the legs, and cervical spine in elongation of the rest of the spine. So inhale here, very good. Exhale, keep the spine long. And again up, inhale and exhale. You can gently move the body back and forward like a swing, very gently if it feels comfortable. to increase the flexion in the hips, to increase the extension by keeping the neutral lumbar spine and postero-lateral parts of abdominal wall still open. And then slowly come down and relax. So another position that helps to open the chest more, to helps to stretch the Pec Major fascia, Pec Minor fascia, helps to relax those muscles that are leading or moving the shoulders in a protraction and then chest down, is an exercise in a standing position, because we are mainly standing during the day. This exercise can be done in the door, which is the most convenient way how to do it, in an indoor door. And you place one arm with forearm on the wall of the door. The elbow is gently elevated above the shoulder level. You can have more variations how much to elevate the elbow. Then the leg that is closer to the wall steps forward. And because of anterior pelvic tilt, I always do with pregnant ladies that they bend both knees gently and they tuck the pelvis gently back, which activates the abdominal wall. It shifts the baby a little bit more backwards because we created a space in a posterior abdominal wall. And we try to keep diaphragm and pelvic floor as much parallel as possible. Trunk is elongated, the thoracic spine is elongated. We already know that from the other exercises. Again, a little bit more, the posterior pelvic tilt. So we are not working only on the thoracic spine, on the pec fascia, but we are integrating the whole exercise in the whole global pattern. So then you support on the forearm and you gently turn the trunk to the left, keeping the diaphragm and pelvic floor as much parallel as possible, coral position of the shoulder blades. And you keep breathing. You try to breathe in this upper area. You try to breathe in postero-lateral abdominal wall. Then you relax and then you go again. So neutral pelvis position, uprighted thoracic spine, coral position of the shoulder blades. Then support on the forearm and gently turn the chest to the left. And to be exercise, to be functional, you have to keep breathing in this position. So you can also inhale in this stretched area. Very good. Relax and then you repeat to the other side. After all the exercises and soft tissue techniques, you can check the stance again. So what we can see is she's standing with a little bit smaller base of support. Pelvis is still in anterior pelvic tilt. The left thoracobrachial triangle is still a little bit more smaller, but what we can see is that the lower abdominal wall, especially on the left side, is not so much in tension. But I can see the huge difference in position of the chest. The chest looks more uprighted, like a longer from the frontal side. And you can also see that there is a much more space in upper abdominal wall for the baby, and she's breathing more to the sides. So from the view from the back, if we can have a look, base of support is smaller. We still can see quite big anterior pelvic tilt, but the elongation of the lumbar spine and uprighting of the chest is much better. What has improved a lot is the lateral shift of the pelvis. The pelvis is in neutral position in frontal plane now. And now can we have a look from the side? Perfect. So here we can again see that the chest is a little bit more open. Lumbar spine a little bit longer. And maybe if we correct it even more actively, so can you please gently shift the weight backwards on your heels and tilt the pelvis and upright from the thoracic spine, more up, be taller. Don't move back, but be taller. Very good. Nice. And we can see that the lady has even more capacity in active correction of her posture. Perfect. Thank you. So you could see we can use almost all positions from DNS except 3 months prone positions in late pregnancies. This position can be replaced by quadruped position, bear position, or low kneeling position. Primarily, we take care of ladies with pain or discomfort as they can create problems during the labor. But we can be also very helpful in cases of physiological pregnancy. We can centrate the posture of mother much better. We can help with intra-abdominal pressure distribution and with stereotype of respiration. And we can also centrate the baby into better position. With all these centrations, relaxations and activations, we can decrease the numbers of cesarean sections around the world.